Hello, everyone. Welcome to this next session, 2026 Outlook for Rural and Community Hospitals. I'm Jennifer Kern, Senior Manager of Content Solutions for the Modern Healthcare Content Studio, and it is my pleasure to be moderating this panel. I'm joined by Jim Kendrick, President and CEO of Community Hospital Corporation, alongside Justin Doss, who is the CEO of Baptist Hospitals of Southeast Texas, Joe Theine, who is CEO of Southwest Health Systems in Colorado, and Frank Corcoran, CEO of Lane Regional Medical Center in Louisiana. These hospital CEOs have fostered a culture of engagement that has led to better patient care and improved organizational performance. And they'll be sharing how they are leading transformation in their communities and shaping what's next for rural and community hospitals nationwide. Thank you all for being here with us today. So let's dive in. Let's start by discussing changes in the delivery of healthcare services. And I want to start with you, Joe. What are some of the challenges that community hospitals will face in 2026?
Jennifer, thanks for having us and asking. We've got all the normal challenges that we're facing. So we'll have increasing inflation and costs, some of the challenges with labor supply and demand, but 2026, I anticipate is also going to be colored by what's happening at a federal level and in many cases at a state level with policy. One of the first things that's likely to be on our radar next year is what happens with the enhanced premium tax credits and whether some version of that is extended or there's something put in place of that. But the risk is that we'll have patients that rely on the small market or the small group market or individual market that end up not being covered as a result of premiums increasing. And for rural and community hospitals, often we're serving such a large number of people that are served by either Medicare or Medicaid that that small amount of commercial business can be the difference between having a margin or no margin, sustaining all of the services we provide, or having challenges keeping those open. So that's the first thing that I think is going to come from a federal side. And then we have the longer discussions around Medicaid, what may be happening with work requirements and how we're planning for that. While we don't expect them to be enacted next year, we'll have to start thinking about and planning for what that looks like in our individual communities. And then on the Medicare side, we still have some of the challenges with Medicare Advantage. And oftentimes the payer policies that result in denials of care, either not prior authorizing something or after we've provided the service, not paying for something or not authorizing it. And we continue to see changes in the Medicare Advantage landscape, either new entrants into rural markets. In some cases, we have Medicare Advantage plans that are leaving, that are making it confusing for consumers to know what to enroll in next year. So I think those pieces will come into play. And on the Medicaid side, I think this is going to vary a lot state by state. In Colorado, we have some limitations on taxes that can be raised and how our government can spend money at a state level. And some of those things are really going to place pressure on our state level budget. And so that may result in decreases in provider reimbursement, decreases in eligibility for some Medicaid patients, or decreases in benefits or changes in benefit structure. And any one or combination of those three things ultimately will affect people who live in rural communities and the payments that providers receive next year. So there's a myriad of things happening, the normal stuff, but then federal and state policy is certainly going to color what we need to be challenged with next year.
How about the rest of you? Challenges that you're expecting to see in 2026?
I'll say one of the things for Baptist hospitals in Southeast Texas, but really kind of all rural healthcare, is we're seeing more and more and faster regulation change from anything from 340B to just your standard compliance with Medicare. And so many of these rural hospitals have very lean leadership teams. You may have a CEO and just a CNO. You might not even have a vice president of operations. And so when you're looking at the immense amount of changes coming your direction and you're trying to manage that, you're trying to build programs and invest in your hospital and invest in the community, it's a lot of plates to keep spinning up in the air. And so I think all of us are always, we're reaching out to lifelines, asking how another hospital might have done something. For us, we're a part of Community Hospital Corporation, reaching up to our corporate office, and there's a great depth of experience up there that we're able to pull from. But I think, the 340B is something that's definitely on everybody's mind. There's so many changes coming around that program. And when you look at, some of those proposed changes, a substantial change or a misstep in terms of your compliance around a program that important could completely wipe out any margin that a hospital may have. And without that margin, there really is no mission.
Hey, I would like to echo Joe and Justin. Everything they're talking about is spot on. What we're seeing here over at Lane. One of the things, my big concern here at Lane is we have some what we call state-directed payments for Medicaid utilization. And we're seeing that potentially go away in 2 years. So how do you compensate for that and plan for that? My personal strategy is let's look at investing in service lines that we can grow revenue versus trying to cut to it. So those are some of the strategies I'm using. But, in the bigger picture, we're looking at some cuts coming down from the federal side that a lot of rural hospitals, community hospitals survive on. And it's going to be a gamesmanship between, the Republicans and the Democrats up there in Washington to how are we going to settle this big controversy and how are we going to take care of the Medicaid patients we're taking care of now.
Yeah, I would also mirror some of the comments that were made. I think Joe touched on the fact that his hospital, large proportion of the people that are paying for services are coming through a government program, either Medicaid or Medicare. And then you get Medicaid, Medicare, and then managed Medicare. So those managed Medicare programs are continuing to make it more difficult for hospitals to get paid accurately for the services they're providing. The cuts on Medicaid, the increased pressures on Medicare. So if all of your payment is highly contingent on the government, and the government is in a retraction mode in paying for those services, I think we have to do a good job of vocalizing the impact that's going to have on people that won't be able to get the care that they want, so that they have the importance of the issues in front of them when they're going to vote, because we have to get people to understand the elected officials are the ones who are deciding the dollars that flow to us, and those dollars that flow to us are how we're able to meet the needs of the communities that we're serving.
Well, that's a good transition to our next question, which is, what are the funding opportunities that are there to help community hospitals overcome these challenges?
So I'll start with that. Probably one of the biggest ones that's on the radar that people need to be paying attention to is the Rural Health Transformation Program. That's the $50 billion. So most of us in the industry have heard about the $50 billion, but getting into the weeds of that is very important. First, 50% of it is spread equally among all the states. So they're taking $25 billion, splitting it equally among all the different states. And then the other $25 billion, now your states have already done this because the deadline to turn it in was in November. So every state in the country turned in an application to get a piece of those additional funds. Now, in the equal distribution among all 25 states, there's some states that hardly have any rural hospitals. Okay, then you have some states like Texas that has lots of rural hospitals, and Colorado and Louisiana represented on the phone today, a lot of rural hospitals. So there's a little bit of imbalance associated with simply taking half of the fund and distributing it equally. But even when you go there, the other 25 billion, every state has turned in an application. Now, if you look at the frequently asked questions on CMS's website about this, they kind of indicate that about 25% of the states will get dollars from that other 25 billion. Now, also keep in mind that 50 billion is spread out over 10 years. Okay, so you're really talking about 5 billion a year, half of it going fixed equally among all states, the other half based off of what your states have turned in. And I would advise everyone to get very close with their state associations in understanding what their state has asked for. How are they going to be accessing the dollars that are in that additional 25 billion, i.e. 5 billion a year. And now that doesn't mean the 5 billion a year is equally distributed among the states. Like they said in their frequently asked questions, it may only be 25% of the other states that are getting those dollars. So you may have opportunity to get more dollars in that space than they already allocated. But even in the already allocated, a lot of times people brush over that because they think that's the equal distribution. But again, how is your state going to use that equal distribution? Okay, there's some limitations on what they can do, but there's some pretty broad things that you can do that will really be able to help your hospital. There are states that did not expand Medicaid, and those states that didn't expand Medicaid won't have all of the same negative impacts of the One Big Beautiful Bill rollout in reduction in covered lives in Medicaid because they didn't expand Medicaid, but also because they also don't have the same dollar impacts going forward. So there's a lot of complexity associated with it. And I would say that is the biggest dollar resource that's out there for the rural hospital, and getting your arms around what it means for you, for your state specifically, your hospital specifically. And are you working to try to make sure the vehicle that your state has identified to try to get dollars in, that you're aligned with to get those dollars to help you out? No one looks at this and says it's going to be an offset completely, because it's an attempt to help lessen the burden, but it's not going to be a complete offset. And it's also right now a 10-year program. So what happens after that 10 years? I'll leave it open for some other people to comment.
Yeah, I'd like to add to that, Jennifer. Thank you. Jim is painting a picture for us. We need to get involved with our state associations to figure out where that money is going, and we're dependent on the states being transparent. Where is that money going? Once it gets allocated to the states, how do they distribute it equally, fairly amongst all the hospitals and the rural hospitals? Because there is a lot of dollars at stake here, and everybody's got looking for some help or some access to these dollars. So it's really important for the hospital associations to work with the states to say, hey, how can we do this evenly? How can we be fair about it? How can we help the hospitals who are struggling with this?
I'll add to Frank and Jim's thoughts. We've got this federal tranche of money that's going to come on a one-time basis. And then we also have to look at where are the other spheres of influence that we have around funding. And so really getting engaged on the philanthropic side and telling our story about how important a local hospital is to the community, not just for access to care and improving people's health, but also we're economic drivers. We're often, the first, second, or third largest employer in a county and in a rural community. And then also looking to those next tier of businesses. Often local governments may be self-funded in their own insurance plans, and they haven't taken a close look at how they structure their benefits for their employees. Are there opportunities to partner in ways that the local government, the local school district may benefit by having their own employees seen locally? Could that reduce their costs at a time when their budgets are also stretched and keep more care local versus families and patients having to travel a long distance for care just because they didn't structure their benefit plan in a way that benefited everybody? So I think there's some other opportunities outside of the large federal tranche of money that's coming. I also completely agree with Frank. We've got to get aligned with our state associations and be active in the discussions about what our states do with the federal money that's coming our way.
Yeah, and I would just say, now's the opportunity. Build those relationships with your legislators. I mean, build a relationship where they trust you when you go and you say, hey, this is going to hurt me, and here's the data behind that. And this is why I could prove that this is going to be a bad thing for the community that you were elected to represent. And people love stories. Connect to purpose with that. I think all of us round on patients, probably every single day. And you hear some of these heartbreaking stories of these patients that are either, unfunded or underfunded, which is another real burden that's out there. And being able to go out there and tell those stories appropriately in a way that gets the message across and gets the end result, which is we need help. If you want us to be here and serve the communities, we need help.
So I want to follow up on what you said a minute ago, Joe. You talked about partners, and Jim, maybe you could start on this one. What types of healthcare delivery models and partnerships are emerging in response to this current environment?
Well, something that I think you set the stage with is understanding the challenges we're facing are at a higher level of magnitude than they have been in a long time. Now, this industry is always challenged. Everyone's always trying to cause the spend to be less and the service to be greater. But the last time we had any significant change of this magnitude of what we see coming now was the Balanced Budget Act of 1997. Okay, go back to that, and you saw over 100 hospitals, I think 150 hospitals closed across the country. Okay, now that caused a backlash. It caused people to say, okay, wait a minute, we can't lose our hospitals. I often try to draw the comparison to, police, fire. When you have a problem and you call 911, you expect a policeman to be there. When you have a fire in your house, you call 911, you expect a fire department to show up. Well, those organizations are supported by tax dollars. Okay. The healthcare industry has some aspect of that. Again, our largest payers are the government through Medicare and Medicaid, and we may have state programs for providing additional tax dollars. There may be local districts that are providing additional tax dollars. But understanding that and communicating that they are at risk of going away. And with these changes that we're facing right now, again, we're at that next level of major significant change that can cause a lot of hospitals to go away. A little over a year ago, you would hear people say 50% of all American hospitals were losing money. That number's improved. The number you hear now is around 40%. But 40% of American hospitals are losing money. Well, that's a disproportionate answer to the rural market, because when you say that 40% are losing money, that's a large portion of the metropolitans maybe not losing money. So you have actually more than 40% in the rural market. So if we're at risk of going away, then we have to look at ways to change our delivery model and find new partners to align with. One of the important alignments that we need to work on is getting away from being seen as the big expense and the problem, opposed to being the resource, like when you call 911 for the fire department, when you call 911 for the police. We're there to help and serve our community. We're not the problem. Okay. Now, because we've got that different distance between the models, sometimes employers saying, this is the largest line item on my expenses and it's going up every year on a disproportionate level that I can't afford. We don't disagree with you, but understand many of the costs that are driving up in the healthcare arena fall in things like regulatory compliance. We're spending more dollars on non-clinical providers to meet all the criteria, to jump through all the hoops so that an insurance company fairly pays us for the services we provided. So more and more dollars are going to non-clinical care. We would prefer that not to be there, but if we're going to get paid fairly for what we do, we have to have those resources. So part of it is getting into partnerships with employers, so giving them insight to what we're doing. Okay, if we're serving a large employer in our community, they need to understand we're not printing money over here. So a lot of times they think, these hospitals are making all this money and they're just asking for help. That's not the case. Again, 40% of all hospitals in America are losing money, disproportionate to the rural market. But in those partnerships, again, education is key, letting the employers understand the value that we're bringing, letting the community leaders understand, both legislative and local government, understand if a hospital goes away, your community's in trouble. Okay. That's not just rhetoric, that's fact. Go back and look at places that have lost their hospital and the impact that incurs on their community. The other piece of that is delivery models. If there are more efficient ways to deliver care, or if there are things that you need to consider, we definitely need to be chasing every avenue that we can in that area. Example being, if you have a small rural hospital and it has a very, very small inpatient book of business, then it may have to make a change in its structure. Okay. There's a new federal designation called a rural emergency hospital. Okay. So if you have a very small inpatient book of business, but you're still serving a vital need for caring for the people in your community, maybe go to a rural emergency hospital. Well, that's scary for a local board, because what it means is they have to give up their inpatient care. Okay. Well, there's still a lot of services they can provide, and it may be the safety net that they're able to provide it with under that model. There's other models where you need to be focusing on collaboration and partnering with other providers. One of the issues in rural markets is many times they're independent. And being independent, you don't have the scale. Okay, scale makes more efficiency, makes the dollar go further. So finding ways to partner with other people that are in your region, in your area, and try to collaborate on the delivery of care. Again, you hear about all the hospitals that close, but there's actually a much larger number of hospitals that are going into mergers or partnerships with other organizations. Make sure your company, your hospital is in driving that, opposed to having to react to that. Know the direction of your financials so that you can respond to it accurately and be positioned to partner and align. There's a lot of other things. I don't want to go on too long because I don't want to overstate the comment on this question, but things like Medicare Advantage. Okay, Medicare Advantage is something that is going to continue to put critical access hospitals at risk. A critical access hospital is a cost-based reimbursement model. And you basically, for all the care that you're providing that's going to that Medicare recipient, you can show if your costs are higher than you're getting paid, you'll get that back on your cost report. Well, a Medicare Advantage plan doesn't count toward that. Now that 50% or greater of people that are on Medicare are on a Medicare Advantage, you're going to continue to see critical access hospitals struggle with the math as more and more people go into those type of plans. So understanding your numbers, understanding with the impact you have, working with employers, working with other providers, that's kind of an overarching answer to, you have to find ways to deliver care in a more cost-effective manner, and a manner that delivers as much as you can with the limited resources and the continuing reduction in those resources.
So let's pivot to the workforce challenges at the moment. I want to start with you, Joe. How do you make your community and your hospital an attractive place for physicians to want to live and to work?
We're fortunate in some ways. Southwest Colorado's got a lot of natural beauty to it, but every rural community is small, and it's close knit and doesn't have some of the conveniences of living in an urban environment. When we recruit physicians out, what we really try and do is show the best of our community when someone comes out. We invite their whole family, especially the spouse. Often the kids will come out with them, and we do our best to invite them to really come spend many days here. And honestly, most of the time we spend is not walking around the hospital. It's not talking about the care delivery piece. We certainly do that, but we really connect the family up with others who live and work in the community outside of our hospital, doing activities that they might enjoy if they were going to live here. And we put some structure around that. So we actually have a curated group of community members that have said they're willing to volunteer their time, spend time with families who are interested in moving to the area. We have a sense of the age of the kids of the family, or if they're retired, what professions they've been in, what activities they enjoy. And as we're getting to know physicians and their family before they come out, we're actively listening for and trying to understand why they might want to live here. And when they come, we then connect them with other people in the community. We've had families go on hikes with community members. We've had superintendents of the local school district take the family out to dinner rather than it being the hospital team or the providers. That's the level of engagement that we've had. And what we find is when people see the best of the community and they already know that, this is a rural community and not an urban community, when they're thinking about our rural community versus somebody else's, they leave here picturing what it would look like to live here. And as a result of that, over the last several years, we've been really successful in recruiting. Without getting into all the stats, every offer that we've made but one for about 18 months was accepted. And so we just had a phenomenal group of people, our medical staff, community members, showing off the best of the communities. And that's been really important for us in terms of the physician workforce and attracting and then ultimately retaining people to be a part of our community.
So how about you, Frank? What kinds of staffing innovations have you implemented at Lane Regional?
First it all starts with investing in your staff. You have to invest in education. One of the best places to start is your hospital association. Our hospital association puts on a number of classes for staff to go to, from senior management, senior level, to just some basic stuff for the frontline staff member. So I encourage and provide a lot of room for staff to go those avenues and get that education. We do also look at what consultants do we need to bring in to maybe educate a larger group here, get a bigger bang for our buck. When I first got to Lane, we're having problems with building a new tower, but our environment of care wasn't quite what we needed for the regulatory pieces of it. So we brought in a group to come teach us how to do the environment of care to be ready for regulations and our joint commission, so to say. So we're meeting all the standards, and so sometimes you got to bring those consultants in. Other things is I'm a rounder by nature, so I typically round every day on the staff that are here. And once they see me coming through the first time when I got here, they were all shocked at it. One, that I talked to some of them and asked their opinions. The other thing is they get used to me, and then they don't have a problem coming to me with an issue or an idea. And more likely than not, they come up with ideas they want to run by the CEO when I'll come around. And that's frequent. So I make that a daily process to just round and touch base with staff, just to be there, be present. I always tell them I'm here for three things. I'm here for one, the patients, two, the staff, and then three, the community. And I try to live by that. And so I tell them, we have to take care of the patients, but I have to take care of the staff. That's my job. Make sure you guys have what you need to do the job, the right tools, make sure you're invested. And they really love that engagement. They love being part of it. We use them if we're making a decision. We try to get their input into a new decision or a new tool so they feel part of the process and they're not just dictated to or handed, hey, here's our new process we're doing. It's like, let them be part of it. Other things we've done recently is let's do hospital week. Let's celebrate it up. Let's make it a big success story. So we did that in Louisiana. We do crawfish boils. And so the staff had always had hamburgers and hot dogs for hospital week. So let's do a crawfish boil. And we got a sponsor out in the community to sponsor us and help us do the crawfish boil. So the staff really engage into those things. They love that attention. And to me, the more attention you can give them, the more engaged they are. We are one of 7 4-star quality hospitals in the state of Louisiana. And we're proud of that. We just did a celebration for that 4-star thing. We like to give T-shirts away when we're celebrating stuff. So the staff all got these, hey, Lane's 4 stars, let's celebrate, but let's get that out into the community. Let everybody know we're 4-star quality. You don't have to go to Baton Rouge, about 15 miles north of us, to the big town when we have all the quality care here. And we're the only 4-star quality in the Baton Rouge area. So we pride ourselves on that. So again, getting the staff engaged in what you're doing, it makes a big difference in training, recruiting. You just want them all be part of it.
And Justin, are there any particular programs that you found successful to foster long-term recruiting efforts at Baptist hospitals of Southeast Texas?
Yeah. One of the things that we've done with our staff is we really bring them down into the administration. We meet with them. Like Joe talked about actively listening. We do the same. We actively listen and then respond back to them. And that's shown in our employee engagement results. We've been over the 90th percentile for the last several years. As a matter of fact, Forbes recognized us as one of the best employers of America just recently, which was a huge accomplishment. But when you're going through there and you're looking at things like that and you're giving the staff a reason to be proud of their home, I mean, this is their home. They spend more time here than they may do at their house. And if they're proud of it, they're probably not going to leave, that place, not easily. One of the things that we saw even on the physician side of the equation, so many of those physicians talked about either they were chief resident, they talked about they might have had academic teaching experience in there. And as we're actively listening to them, we're like, we have the makings to be able to move forward with a GME program. And so about 3 years ago, we went through and we started up an internal medicine residency program. I have over 40 residents, now training our own physicians to hopefully stay here in the community and continue serving our community. I have over a dozen psychiatric residents that are here to be able to go through there and serve the community. And that 100% came out of actively listening. We have a lot of 2-year nurses that are out there. And so we went through and created a partnership with Lamar State College, Port Arthur, and we're actually now designated as an extension site. And so these LVNs that were, working in our hospitals that had a desire to go on and better themselves and become RNs out there would have to get off work and they would have to drive the 30 miles south to sit through classes and then figure out, where they're going to do their clinical training. And so we just said, we can do better. And so we actually became an extension site of that college and it's here on site. And so the staff members, they can do their clinicals and their didactic training here at the hospital. We just started that about 2 years ago. First class came through. We had a 100% pass rate on our NCLEX. So better than the main campus was even doing. And so if you're going through there and you're actively listening, you're trying to respond and really treat people like true family, it's absolutely wonderful. And it doesn't hurt that we're also the only hospital in Southeast Texas that bonuses every single employee in the hospital if we meet our quality metrics and our financial metrics. And I can't think of the last year that our employees did not hit those bonuses. And so when you think about, those checks, and, $1,000, $2,000, they come out. Actually, we just distributed them just a couple of weeks ago. And this close to Christmas, just to see the smile on their faces. And that certainly helps to be able to give back.
Well, in a few minutes that we still have together, I want to pivot to innovation and alliances. And I want to start with you, Frank. How do community hospitals determine where best to innovate?
First, for me, it starts with the strategic plan. You develop a strategic plan that's going to move your hospital forward. So within that strategic plan, I like to find out, where can I innovate? How do I think outside the box on certain things? When I got here to Lane, first thing I noticed was we were sending out 20 neurology or nephrology patients out a month. Behavioral health, I'm sending out 40 patients a month, at least 40. So to me, and then you look at the community needs assessment that we do every couple of years, it sticks out. So how can I do that? Okay, trying to recruit a neurologist full time may not be successful, or a nephrologist. However, we've innovated with telemedicine. So I've brought in a telemedicine neurologist who will not only just see patients in the ER as they're having maybe a potential stroke, but what about these seizure patients or patients with neurostatus changes? He'll see them in the ER, but then he'll follow them through the hospital. So we will admit them under the hospital medicine program, and the neurologist will consult and follow the patient. Same thing with nephrology. I brought in a nephrologist through telemedicine who helps me. One, he helps me cover critical care, but then we were sending these patients out routinely, and now we're starting to keep them. We're starting to innovate with a dialysis plan, so we don't have a dialysis center here at the hospital. There's one in town, so we don't really need to go into that avenue, but there is some modifications to dialysis where we could do on an inpatient side that doesn't require to buy all the equipment. It's a little bit modified, and it's perfect for the acute patient for the acute episode. So to me, telemedicine's been a big focus for me to innovate. And now I have those services here. Those patients aren't being shipped out. And then we talked to our EMS groups. There's a couple of EMS groups in town. We told them, hey, we now have this, because they were on autopilot. If they picked up somebody with a seizure or urinary problem or nephrology problem, they just taken them off to the other campuses. So we let them know, hey, we have this now. They're starting to bring patients to us. So to me, that's been our big thing. Communication of the strategic plan. We do a huddle every day. And it started out as a safety huddle, but it's also a time for to communicate what's going on, how we're doing, what services we're bringing in. And that gets emailed to every staff member. So, they don't, the frontline staff typically don't participate in the huddle, but their directors do, and they pass that information. But as we email it out, everybody knows what's going on in the safety huddle. And that's a daily occurrence for us. And then lastly, the community focus. Our hospital is focused on the community. We are out in every community event that's out there. It's like, let's just put up a tent, hand out water, anything's going on. And the community has embraced us and has accepted Lane. We're their hospital, and we're not just for Zachary, Louisiana. We have the city of Baker to our south, Central to our west, and north of us, all the way to the Mississippi line, if you know where Zachary is, we have a large catchment area in our secondary market, which there's only one critical access hospital there. So we partner with them to work together. Hey, what can you send us? I'm going to send your patients back to you, but if we need services, send them here. So we're out there all over the communities, and we participate. We have members on everybody's board, each big city. We have a staff member, somebody's from our leadership on these boards to help bring Zachary in. So, just getting out into the community also makes a difference.
Well, you touched on technology, and I want to direct this to you, Justin. How can community hospitals afford and adopt IT advances?
Well, one thing is trust the data. Just you've got to stay in front of it. You can't get behind the curve when it comes to investing in your IT and infrastructure. Back behind that, one of the things that we do at the hospital is we actually keep our leader for IT. He sits at the executive table with us. He is there for every executive roundtable that we do. He's providing input into the various strategies. And so as opposed to, buying the latest piece of equipment and getting it to your front doorstep and then figuring out, you don't have the right, IT services to be able to even service this thing. And it's going to take you another $300,000 to be able to go through there and do that. As we're going through there and we're doing our budgeting for the hospital, to have him at the table and be able to say, okay, your servers are getting ready to go down, your phone system's getting ready to go down. We need to start planning for the next 3, 4, 5 years on what our investment strategy is going to look like for that. All the hospitals right now are at risk for cyber events, cyber attacks at the hospital. And so you've got to be able to weigh that out. And you get older technology that's vulnerable to those attacks. It can really lead to a disaster. Even if you have the latest technology, it can still be tough to be able to climb through that. Looking out to outside resources, to make sure that you have the right strategy. And so, sometimes in rural healthcare, it's tough having a subject matter expert that really understands all the different nuances about what goes on in a hospital. So being able to reach out to those outside resources, be able to say, hey, this is a strategy we're kind of thinking about. Litmus test this for me. Tell me, like, where are my holes? What else can we do? And being able to make sure that when you go through and you make a $300,000 or $500,000 investment, that you at least have somebody else be able to say, yeah, that's the right direction. We agree with that strategy. Being smart about how you're deploying that capital. A lot of hospitals don't have $300,000 to deploy on servers. And so do you go through there and, you expand on cloud-based servers? That gives you a lot of variability and flexibility in terms of as your business expands and contracts, you're able to modify, what you need from a data usage standpoint. The cybersecurity piece of it, another, just huge piece. I can't say that enough. Making sure that you have your plan ready before you need the plan. I can't tell you how many hospitals have called us over the last couple of years saying, hey, I heard y'all went through an issue. Can you please come speak to us? Even here in Beaumont, that has a number of very large institutions, including the city. The city actually asked us to come and speak to them about our cybersecurity plan and be a resource to them. So just keeping it at the forefront, don't lose sight of it. Even when you're looking at other priorities and other issues, just know that that's some medicine you kind of have to swallow. You gotta be able to be ready and prepare for it, and then make that investment when the time comes.
Justin, one thing I wanted to add to that real quick is there is a federal funded program called USAC, and CHC helps hospitals access USAC funds, but that's a way to bring dollars back to rural hospitals that are spending money on technology. It gets you dollars back that you've already spent, and it doesn't cost you anything if you don't get those dollars back. So the USAC program is something that rural market, hospitals definitely need to be paying attention to.
Joe, I want to touch real quickly on specialty care. What's the best way to provide specialty care without doing it all yourself?
Yeah, I think it starts by going back to one thing Frank touched on, which is the importance of having facts and data and a strategic plan. So starting by understanding your market. In our case, we were able to get a really good market analysis and really understand from a demographic side, both number of people and age, what specialties could we support with a full-time provider versus which would we just not have the demand for on a full-time basis, but still really important in improving the health of people who are here. And based on kind of that split, then for some specialties, it might be better to be part of a group than to be out on an island. So in two cases, one in oncology and one in cardiology, we've partnered with other hospitals in the region, but we're doing it in a way that we're asking them to have a person in their group that actually lives and works in our community. So often there's a hub and spoke model where somebody may come out, do some work, but go back to their hub. When we've identified that there's a need for a full-time provider, we're accepting nothing less than a partnership where a regional hospital will place a full-time provider in our community. Again, we want them to be a part of this. And then there's a consistent person for that service. The physician or the provider wins because they're connected to a larger group. And when they need to consult with somebody, maybe when they're taking some time off, a partner of theirs can rotate through. And then when they need access to resources that we're not large enough to have, they've got a direct line of referral into a larger group, rather than if we hired them to put them on an island. So we've been successful at that in a couple of fronts. And then that other tier where maybe the demographics and the population doesn't support a full-time provider, going back to regional partners and saying, boy, what would it look like for you to rotate somebody out here? What's that frequency? How do we keep them busy so their time's well spent when they're out here? And again, knowing your market and the demands can really help inform those decisions and make sure all the parties are doing well. Most importantly, the people we're delivering care are getting improved access to their care. And for us, we're a local independent hospital. We're not part of a large health system. And we have decided that we want many partnerships as opposed to in some of the earlier discussions, going through a merger or an acquisition or a significant affiliation where you only end up with one partner. We're really looking for the best of different organizations to be a part of our community, and that strengthens our independence rather than hinders it.
in just the couple of minutes we have left here, I'd like to hear from each of you kind of one key takeaway. So if a community or rural hospital CEO is watching this, what are the top, just maybe one key takeaway, the top action that they should take as they go into 2026? Let's start with you, Jim.
I would say making sure you understand your financial situation in absolute detail, not just where it's at today, but where it will be with the things that are coming. We can look at a lot of these federal things that are going on and they roll out over the next 10 years. Depending on what state you're in, they roll out at a higher level of magnitude, but understand your data in great detail. If you don't understand your data in great detail because of the resources you have to try to ascertain that, then work with someone to help you, because you have to understand where you're at. And if where you're at is on a trajectory of inability to sustain care for your community, don't be quiet. Be talking to your legislative officials, both state and federal level, and say these changes are going to cause our hospital to go away. It's not a sign of failure if the government pulls back a large portion of your reimbursement, and that's just covering your fixed cost. So make sure you understand your data, communicate the needs that you have, and make sure that the people in your community know where you're at. Don't let them be surprised. Don't come out and announce that your hospital is going to have to close or cut services because of these changes when they're coming a year in advance. Find out where you're at, be articulate about that, communicate that, and make sure people understand the consequences of things that are happening in the healthcare industry.
Frank, how about you? Just one key takeaway.
Yeah, just to come off of what Jim is discussing, being actively involved with your legislators. I know each of us have probably said that throughout this panel, but being out there actively engaged, what we learned is not just the local legislators, but federal. If you get a chance to go up to the AHA meetings, we do that and take that time to go meet with our federal legislators, our senators and representatives, and telling our story and how the changes that they are planning or things they're looking at, how it's going to affect us, how it's going to affect the hospitals here, the community hospitals or rural hospitals. Being able to tell that story, because you never know when someone is going to pick up that story and then put that out there and use it as a catalyst to get something done. The other piece is payer reform. We've all talked about, we're going to look at stuff being cut back, state-directed payments, things going away, different reimbursement strategies going down. The one thing we need to fight is the payer denials. And payer reform, to me, is one of the things we need to really focus on as the healthcare organizations across the country. We get denials, 10, 20% sometimes. And it's just almost a game they're playing on the payer side is, hey, if you don't fight this, then, hey, we've made more money. So you need to fight them actively. And it's getting into an AI war eventually. AI is on the payer side of reviewing your claims and passing them on and denying them. Now we need to get AI on our side to start doing that. So some more technology is going to be involved. And I can just see this blossoming as our AI is fighting the AI of the payers to see how we all get paid.
Justin, Joe, a quick, brief takeaway.
Just in addition to what everyone else has said, I think looking for partnerships, and whether it's with an organization like Community Hospital Corporation, some of the other hospitals that are in our region, local employers, local businesses. I think getting off an island and finding others that have a common interest or a common set of skills or the skills that you don't have, but look for partnerships to be successful.
And I'm going to expand on Jim's piece in there because that's absolutely the right answer. Know your data. But when you say know your data, don't just memorize the numbers out there. Be able to go 3 levels deep on any number that's out there. If your ER visits are up or down, understand why are they up or down? Was your EMS traffic up or down? What's driving that? What's causing that? And if it's a positive thing, find out how to replicate it. If it's a negative thing, find out how to fix it. But when you know your data, be able to go 3 levels deep, and that's going to help you go much, much farther.
Well, we are now at the end of our time together. I want to thank all of our panelists so much for taking the time to join us for this great conversation. And to our audience, thank you for tuning in. We hope this conversation has been helpful. Please stay tuned as we continue this virtual briefing, looking ahead to 2026.